Welcome everybody. My name is Rich Hooks-Wayman, and I'd like to welcome you to this CLE, Medicaid's role in creating housing and ending homelessness. The goal of today's CLE is to provide you with some information about a sea change that has happened through healthcare reform around the opportunity to pull down Medicaid dollars to offer services to people that are experiencing homelessness in a new way that we were not able to do even 5 years ago. So it's a great opportunity that we want to review with you because we think it will help local communities find resources to end homelessness and expand the supply of permanent supportive housing. We're also going to take some time today to review the Supreme Court ruling from Olmstead and its role in helping people that have disabilities get integrated into communities with supportive housing as well. So today I have several panel members I'd like to introduce with you. And I'd like to welcome you on behalf of several entities of the American Bar Association. This CLE is being taped, and I'd like to welcome anybody to know that there are materials in the back of the room. There are some handouts, but to the extent that there were too many handouts, all of the handouts will be put online at the web page for the American Bar Association's Commission on Homelessness and Poverty. So you'll be able to find all the materials on the Commission's website for homelessness and poverty after this annual meeting today. And I'd also like you to know that we would encourage you to think about questions, but we're going to try to go through the speakers and talk about our topics, and then we'll take questions at the end, I think is what we decided. So if you can just hold your questions to the end. We're going to try to reserve at least a half an hour for questions and just dialogue. We'd like to try to engage you as well on this topic. So I'd also like to recognize that there are several co-sponsors for today's CLE. The Commission on Homelessness and Poverty, the Commission on Youth at Risk, the Health Law section of the ABA, the Commission on Disability Rights, the Division for Public Services, the Real Property section, and the Special Committee on Bioethics and the Law have all contributed towards the organization and facilitation of this CLE today, and we do thank them for their resources and their time. So I would like to now just talk a little bit about my esteemed panels of speakers. To my right is Peggy Bailey. She is with the Corporation for Supportive Housing, and she has a specialty in federal public health and healthcare policies regarding Medicaid. And also then to her right is Elizabeth and Pam. They are with Disability Rights California, a disability organization here in Oakland, California, and they're going to be focusing their remarks on Olmstead today, while Peggy and I will be focusing our remarks mostly on Medicaid and permanent supportive housing. And I'd like to congratulate you for being here on a Friday afternoon late in the week. I know it takes a lot to get here, and so to reward you, I have brought chocolate. So you're not only getting CLE materials, so I'm just going to pass these out. If you can just help me. There's Snickers and Kit Kats and Twix. So I think you should get something the size of ours of this, right? So
they didn't bring it for us.
Oh no.
Where do we put our vote?
Yeah. So welcome, and we are glad you're here. We hope that this will be instructive for you, and we'll try to go now. I'm going to allow Peggy to start off the presentation, and then we'll go from there. So welcome.
Hi, thanks everyone. I think I have to sit down because of the recording, so I apologize for sitting down. I might look fidgety toward the end of my presentation. As Rich said, I'm with CSH. We are a national nonprofit organization, and we're also a community development financial institution. So we help with technical assistance as communities try to create supportive housing for people with disabilities who are at risk or homeless or have housing instability of some sort. But we also have a lending piece. That's what the community development financial institution piece is. So we lend money that's given to us from banks and from the federal government to nonprofits at a really low interest rate. So that helps fund part of my work. And helps the entity get low-cost dollars. That usually is the catalyst for how supportive housing moves forward. So my presentation today will be the overview presentation. I'll help give you an explanation of supportive housing, the challenge of financing the services component of supportive housing, the fact that in order to do that, we need to connect with mainstream health system, which is mostly Medicaid, and learning how to finance our services more through Medicaid. what that means in the context of health reform, what's happening and from a state innovation perspective around health reform for supportive housing, and then some tools of what we're doing to engage policymakers, since so much lies in their plate. So, to take a step back, supportive housing in this context is affordable housing with supportive services. So you can see housing is in the center of the picture, because we feel that housing stability is really the foundation of what people need in order to improve the other parts of their life that they can choose that they choose needs to get better. Whether it's employment services, providing case management, primary care services. And for supportive housing, it's not just people who can't afford housing and may need an occasional doctor's visit. We're talking about a population that is extraordinarily vulnerable, that needs intensive of services, that needs 24/7 case management, that after being housed for a year or two, that's when we start to talk to them about employment, or that's when they usually start to talk to us about employment, and they may need substance use treatment and have behavioral health conditions. So we're talking about housing for a very high need population. And what does that housing look like? It can be in a building, or where maybe you have a building that has 100 apartments in it, and either 100 of those, or 30 of those, or 20 of those are set aside for supportive housing clients. There may be on-site, some small level of on-site services. There may not. Most of the services are going to be provided within the community. It could be a scattered site model where where the apartments are scattered with landlords throughout the community. And then the services definitely are all community-based, and including the case management. It's located with transportation, near employment opportunities, and with shopping and recreation. Often, supportive housing is developed and helps revitalize communities, because it's truly integrated into the community to make sure that people aren't set aside in a special home, or in a special hospital, or a special institution. It really is about creating affordable housing, but there are supports that are accessible by residents. That leads to the fact that the services are voluntary. They're not required to do anything other than what a normal tenant has to do in order to maintain their lease. So it's about helping someone get access to housing, and then helping them communicate to the case manager the care plan that they want in order to address whatever they feel needs to be addressed. That includes substance use too. We don't use supportive housing as a carrot to sobriety. We think that housing, it's really difficult. Supportive housing's history comes from homelessness. And if you think about that, and I know that if I lived on the street, odds are good I would have some sort of substance use problem. So using housing as a carrot for sobriety while someone's in a vulnerable situation is not our philosophy. It's the fact that someone needs a home, and then what we've been able to see through the evidence is they start to make choices about using less and drinking in a more responsible way, and things like that. So to break up supportive housing, really, there's the capital costs of building the building, if we're building a building, and the operating costs, which I'm a health person, I'm not a housing person, so in my lay person terms, it's really the rental. That's the rent, is the operating costs. But supportive housing has a third piece, and that's the services piece. And often services are the hardest to fund. They're usually the last piece of the puzzle. I mean, you got to build the building, and the developer wants to make sure you're going to pay to operate the building, so they're really stringent on that and make sure that's up front. The services piece, they know they need that piece, but the way it all comes together historically has been so fragmented that they just say, okay, well, we're going to find services once the building gets operational, and as long as they say that, we move forward. But that's not enough anymore. We need to make sure that the services are in place and the services financing is solid, and that's why we're looking to Medicaid. And as I mentioned, some of the problems with the services funding is that if we don't look to Medicaid and we try to keep doing it the way that we've been doing it, they're usually short-term federal or local grants They require extensive reporting requirements because each grantor has their own measures with their own requirements of what you have to report back, so you've got to be able to track all those things individually. Not that Medicaid's simple either. I don't want to say that it is, but it's sort of a balancing act, and they're unpredictable. As local dollars and state dollars decrease, then funding for the services decreases with it, and supportive housing is not successful without the services. So that's why we need to look to the mainstream health system. So, but one of the pieces, so as you see, as we try to approach the mainstream health system, they see housing as just a regular social determinant of health, along with race and employment status, poverty, economic class, all those things that the health system sees as a social determinant of health. However, and when they think of housing in that context, they're usually meaning that there's no the location, there's no grocery store, there's no neighborhood supports, or that there's the age of the house because the pipes are bad, or there's mold or lead paint, or there's housing overcrowding because of multiple generations living in a small confined space. But for us, for homeless and chronically ill populations or people who have been institutionalized, the housing is really key to their health. It's more than just a determinant of their health. It completely dictates what their health is going to be like. And that's what CSH has really been working on, is helping the healthcare system understand that, yes, housing is a social determinant of health, but for vulnerable populations, it's more than that. Housing is the health, housing with supportive services is really the health intervention. And we have been able to prove this through evidence over the last 10 to 20 years. We've been able to show that housing impacts someone's health outcomes. Here in San Francisco, there's direct access to housing that's done great evaluation work, and CSH works really closely with. And they've done studies. Chicago, there was a peer-reviewed study that was in Journal for American Medicine that showed improvement of health for people living with AIDS. That's what the PLWA stands for. And Denver, the Colorado Coalition for the Homeless, was able to show improved health outcomes and behavioral health, which is something which is also important. And in Seattle, there's a project that targets chronic inebriates, and they were able to show that reductions in substance use among that population through supportive housing. While we're all, I would imagine if you were drawn to this workshop, you care about making a difference in people's lives, we also have to think about cost. And that usually, and over the last 10 years, we've gotten more and more comfortable with focusing on cost as we try to make the case to policymakers. And those same studies have looked at the cost, particularly around Medicaid costs, and showing that by not serving the vulnerable population, it doesn't mean that Medicaid's not incurring costs. It means that actually they're incurring a lot of costs because people are cycling through emergency rooms or are in inpatient hospital stays or are in nursing homes too long. And we've been able to illustrate that to policymakers, and that's starting to resonate, that you could use Medicaid and we could have a more stable funding stream for services, and you would benefit because your costs would reduce. And that's important, to think about Medicaid in that it's not, Medicaid is an insurance program. It's not a social services program. So they operate just like Blue Cross Blue Shield. They have a bottom line that they have to adhere to, and so we have to approach them in more of a business manner than we might maybe some other social service programs that are more oriented to providing care more generally. So as we talk about Medicaid, that brings me to health reform. It's really important for our population. While I keep saying we're focusing on the most vulnerable folks with disabilities, it doesn't mean that they've had great access to health care. Actually, it means quite the opposite. And it also doesn't mean that they've necessarily been eligible for Medicaid and Medicaid insurance, which is another reason why supportive housing hasn't traditionally connected with it. So now we're looking at health reform. and molding our conversation in the context of health reform. I've already talked about reduced costs. We already have a history of doing that, and we have a history of improving quality. That's what I talked about with the health outcomes, and improving access. And in the health system, that's called the triple aim. And that's really what the health reform is focused around, those three goals. And supposedly we're supposed to get, go ahead, we're supposed to get a higher quality health system out of that, but these concepts are new. Health reform is still being implemented and will continue to be implemented for the next several years. And so there's a lot of uncertainty around health reform. Can we really reduce costs in the way that we say, because now we're going to be accountable for that, and can we improve quality, and are people really going to work together? And for Medicaid, a big piece of that, the thing that we have to understand is, while there are mandatory elements of health reform that we all hear a lot about in the media, unfortunately for the most vulnerable, those parts aren't mandatory. They're optional, and that's what the Supreme Court's case was about last year. And so those options create opportunity. And that's where we as advocates come in and trying to help our states implement health reform and not lose sight of the most vulnerable. Because if we let them implement health reform without thinking about the most vulnerable first, we're not going to see the cost reductions that they want to see, because our folks are going to fall into the high cost population, and it's going to be really difficult to go back and fix later. So we have to be engaged now. So there are two pieces of the puzzle when it comes to Medicaid or health insurance in general. We all have to be eligible for our health insurance, and we have to have benefits. So I'm talking about this earlier. I broke this down in case you're in a state that is not expanding Medicaid to all folks below 138% of poverty, so that you can see that there's also opportunities there too. It's not like, oh, health reform just isn't going to happen. So with health insurance, everyone above 138% of the federal poverty level is going to be a part of the insurance exchanges. That's the piece that's mandatory. So if you don't have employer-based insurance, now you're going to be required to have insurance and most likely buy into the exchange. Enrollment, you're going to start seeing commercials late August, early September about enrollment in those exchanges, and that's going to be the lower to middle class, and almost everybody actually who's going to have to buy into the exchange will have some sort of subsidy in that. For Medicaid, the expansion is for those under 138% of the federal poverty level. They can expand at the state option. It is expected to fill a significant gap for those states that do take up the option, for those who are disabled but not disabled enough to get SSI, and for single adults without kids. And in most states, there's exceptions, but most states will get 100% of their costs from the federal government covered for the first few years, and that will trend down to 90% into 2020. So once folks have health insurance, and remember too that people have Medicaid now, so the disabled population already is on Medicaid. There's possibilities to improve that in states that don't have expanded insurance. Well, once people have insurance, then comes the benefits piece. Right now, there are mandatory benefits that everybody has to have that are primary care, inpatient hospital care, ER, and that EPSDT acronym is early periodic screening, diagnosis, and treatment. That's a kid's benefit that's extraordinarily comprehensive. So if you work with children, they should, assuming they're the providers there to deliver the care that are going to take Medicaid, they have access to a very comprehensive benefit package. Optional benefits include dental, mental health, substance use, home and community-based services, rehabilitation, case management, things like that. And states have ways of expanding those optional benefits through waivers or amendments to their Medicaid state plan. And they can narrow those things down by population. But all of those optional benefits, again, provide opportunity for expanding services for the existing Medicaid population. So again, if you're in a state that's not expanding Medicaid, it doesn't mean that we can't make improvements for at least those who are currently on Medicaid. The newly eligible population, though, in states that are excited and expanding Medicaid, like California, the new law lays out 10 categories of care. which includes ambulances, inpatient care, behavioral health treatment. This is really important because our vulnerable folks in supportive housing, just having basic Medicaid is not going to be enough, because it's only going to cover really not minimal things, but not enough for our intense need folks. And so, while it's great that there are these 10 categories, it's important to see how much within those 10 categories are covered for the newly eligible population, so that we can see what other pieces of the Affordable Care Act we need to implement to supplement what our population needs. And so the way to do that, I've tried to bucket things into different pieces of the Affordable Care Act. So this shows the ways that we can expand services beyond the basic Medicaid package that the newly eligible population will have in order to provide more comprehensive care for our folks. There are home and community-based services, and so those are all sections of the legislation 1959, 1915C, that cover home and community-based services. There are ways states apply to the federal government to be able to use these services for specific populations: elderly, disabled, kids, those with mental health needs. And in that, they outline what services they're going to provide and how and who the providers are going to be. The reason they have to ask for special permission from the federal government is the federal government's got to agree to pay their share of Medicaid. Medicaid is funded through a partnership with the states and the feds. So you've got to ask for permission to do it. You've also, in some other instances, the state may want to narrow down, like in California, they may only want to do it in LA and San Francisco. In order to narrow down, not implement something across the state, you've got to ask for permission from CMS to do those things. The 1115 waivers are another way to expand. And what I included here are things that are not new. So 1115 waiver, again, is not new to the Affordable Care Act. So if you're in a state that's not expanding Medicaid, it's no excuse to try to keep pushing the state. 1115 waivers are very broad. Every state has at least one. Most of them have multiple ones, because it's just showing, you just are asking the federal government to do demonstrations to show cost savings for particular populations and for a particular set of services. The one piece about 1115 waiver is that it has to be cost neutral to the federal government. Of course, states want cost neutrality also, but if that's not required in statute, but being cost neutral to the federal government is required. And there are other things and these two in particular you'll hear Rich talk about. There's targeted case management and the Medicaid rehab option. Both of those are to help specific populations, usually in our context, the mental health population. And you might notice I keep saying the mental health population. Unfortunately, the substance use population has been left behind, so it's another place for advocacy where we really need to make sure that we're but there's no reason why we couldn't use a lot of these things for the substance use community too. To provide services for case management or rehab, which is helping someone relearn or redo tasks that they knew how to do once, but due to illness can't, have lost that ability and need to relearn how to do it. Doing those kinds of services are also to a specific population, or things that the states can ask the federal government for permission to do. So within the Affordable Care Act, so you have those things, a lot of those that I said were existing with it before the Affordable Care Act came along. And now we get to the goals of the Affordable Care Act and what the Affordable Care Act is trying to make us move forward to do. And the simple way to think about it is care coordination. In order to reduce costs, to accomplish a triple aim: reduce costs, improve care, and improve access. And trying to do that for vulnerable populations, because one of the inefficiencies in the system is having to go to having 8 case managers, that one's looking at your diabetes, one is looking at your mental health, one's looking at your substance use. You can't coordinate it, they don't know about each other, and they're not coordinating, and they're all doing different things. So there are different levels to try to improve that coordination. You'll hear providers talk about patient-centered medical homes. That's really the basic kind of coordination that one provider tries to do within its own walls mostly, or at least within a small, tiny network of folks. And really focused usually on clinical care pieces, not mental health or behavioral health. Or, well, behavioral health could do it just for behavioral health, and then it would include clinical care. Then you go to the next step, and it's managed care. And a lot of us who have employer insurance understand what managed care is. So and it's the same thing for us. But traditionally, managed care has not been involved with vulnerable populations. We often get what's called carved out of their plans because they don't want to deal with the hard folks, and that's changing. And it's a good change. It's making managed care serve higher need populations, and what that's doing to them is understanding more about the social determinants of health and housing, and feeling like they need to play a role because they've got to reduce their costs. And so, we sometimes think of managed care as being fairly rigid, but they're starting to apply some innovation too, and CSH has had some great conversations with some of the larger managed care entities about that. The next step is health homes. So you have the health home concept comes from the 60s around pediatric care. And it's the idea that a child should enter into the system, and their providers should all talk to each other, all know what's happening with that child, communicate, share data sources, and be responsible for the care for that child. For a long time, it was thought that that was impossible to do for adults because we're just too complicated. But now with the Affordable Care Act, we've been charged, it's been said, you know what, no, we've got to figure out how to do this for adults, and we don't care that it's complicated. We're going to pay for all that complication. So health homes, so we've gone from medical homes, what it was called for kids, and changed that to health homes to encapsulate the fact that we need to think about behavioral health and social service supports and the complex needs that even the average adult might have. And then the next layer, and so in that creation of health home, we're not talking about just one provider creating that home for someone. It's a network of providers coming together that all share the responsibility for that patient within a set geographic area. Then we get to accountable care organizations, which is even bigger and at a higher level. And within accountable care organizations, you're taking the health home network, making it bigger, and then that accountable care organization is also assuming the risk. So the state may pay that accountable care organization a flat fee to serve all people with mental illness. And then that network of folks has to do that for the cost that the state's paying for, but they have a huge amount of flexibility in the services they can provide and how they're going to control costs for that population and coordinate care. So these are all things that the Affordable Care Act tries to promote. These are the new things that are moving forward, and some of these are even moving forward in states that say they're not taking up the Affordable Care Act, but they really are, like Texas. So I want to get to a little bit of the state innovation so that you can see that in all of this uncertainty, while we know no one obviously has gotten to the finish line, the Affordable Care Act is extraordinarily new, people are taking advantage of the opportunity and really trying to seize the chance that this innovation, that this opportunity allows. In New York, Governor Cuomo had almost the first thing he did when he took office was assign a Medicaid redesign team. They pretty much set up a way to redesign New York's Medicaid in less than a year. And when it came to housing, they not only are looking at how to do Medicaid better connected to housing, but they're realizing that they need to pay for housing. So they've set up a system where, as they control the costs that I mentioned in the cost line, they reinvest those costs back into the system, rather than letting Albany suck up all the costs and spend it on other things. So they've asked for federal permission to do that. We're still waiting to hear if their waiver is going to get approved or not, but we're really excited about them recognizing that not only do we want to achieve savings, but we want to reinvest those savings in the system so that we can keep the system whole. In Portland, or Multnomah County, which I always forget how to spell Multnomah, so I always put Portland. They're accountable care organizations is developing, and it's really exciting. And supportive housing, if anyone knows Central City Concerns in Portland, they're a very large supportive housing provider in the city and play a role throughout the county. And they've been involved in this accountable care organization from day one, really through the force of Ed Blackburn, their executive director. And that's a key piece. Even though the Accountable Care Organization hasn't quite figured out what to do about housing, they know that they need to do something because Ed was at the table at the very beginning, and that's what us as housers have to do, is get them on the table from the beginning. We can't just wait for health reform to happen and then engage. It's a provider-led accountable care organization. They're still in the process of setting up. They have a wide variety of partners, but supportive housing is there as a piece of the board to help figure out not only how to finance the care coordination that's going to happen in the accountable care organization, but link that to case management for supportive housing for the folks that enter into the system. In Chicago, they have a health home initiative that's moving forward. Actually, it's now becoming more of an accountable care organization. In Illinois, anyone from Illinois knows that the state budget, if there's a state that might have a worse off state budget situation than California, it is Illinois. And so they have been weary, while they are definitely expanding Medicaid. I think they just actually approved it just the other day. They have been weary about taking on too much cost because of the state budget problems. So the way that they did it is, instead of asking the federal government for permission to implement health homes, they decided to do it on their own, because that's the key piece, is that even with the tragic budget situation in Illinois, they still want to move forward. So they're using what they have existing in the Medicaid system to reorient that for health home networks. And there are 6 entities that got provided. Each one's focusing on a different population. We care about one that's called Together for Health, that's forming in Chicago. And supportive housing is at the table. We even have a seat at the board, on the board. And again, it's looking at how to connect and pay for, within the health system, the services that are associated with supportive housing. In Massachusetts, as I mentioned before, managed care is at the table, and they're great. They're a great partner. Massachusetts Housing and Shelter Alliance went to the managed care entity, I think 6 or 7 years ago, and said, we can reduce your costs. You have responsibility for our population, and we can show that we can reduce your costs. You need to pay us to do that. And the managed care entity said, you know what? You're right. Let's try it and see what happens. So they created a benefit called the Community Support Program to End Chronic Homelessness. It's a benefit that includes a large portion of the services in supportive housing. Supportive housing providers don't have to have had a history of billing Medicaid before. They just have to meet certain qualifications to be able to get dollars from the managed care entity. And the managed care entity pays a per person per day rate of $17 a day to the supportive housing provider. And as long as the supportive housing provider puts that person in housing within 60 days and keeps that person in housing and adheres to the requirements of being a high quality supportive housing provider, they get that day rate from the behavioral health entity. And then Massachusetts Housing and Shelter Alliance sort of monitors this so that the managed care entity doesn't have to become an expert in supportive housing. Mahasa watches over the supportive housing providers to make sure they're doing what they're supposed to do and adhering to the tenants. Like, the people don't have to do services that they don't want, but they have all the rights and responsibilities of tenancy, and that the housing is high quality. It's a great example, and they've been doing it for years now, and so now they have data that shows that they can reduce the costs of not only the behavioral health costs, but a huge amount of the primary care costs. Yeah, we like them a lot. And then Louisiana is one of the examples I want to show you of a state that says it's not implementing health reform, but they actually are. They're not doing Medicaid expansion, but through the Home and Community-Based Services waiver, there were improvements made. While that did exist before the Affordable Care Act, there were improvements made in the Affordable Care Act to make it easier for states to use. Louisiana is one of the first states to jump on that opportunity, mostly due to Katrina. It's the timing of Katrina. And so, they're using home and community-based services approved by Medicaid to finance services in scattered site supportive housing throughout the state. It's a great partnership because the housing and the services come together for the person at the same time, they've housed over 1,000 people so far through using the home and community-based services waiver that they have. So I just want to wrap up with just to give you some of the things that we're doing to make this case. As I keep talking about the costs, we've been working on, you'll see back there, I think, a Medicaid business case paper that we did. I don't know if it's back there.
Yes.
Yeah, that we did with the Center for Healthcare Strategies. That was a national study, that was a big picture perspective of the cost for Medicaid and supportive housing. What we're doing is now taking that to the states and doing state-specific business cases. So we're partnering with Medicaid agencies that have great data, looking at their high-cost users, hopefully connecting it with their homelessness data, but usually not necessarily. We're having to make some projections about that because the data systems don't talk to each other. But still, we can show how much of their high-costers need housing, and then make that, tell the state, you will save $1.1 million if you do this. And we've done that in Rhode Island and Washington State so far too, and it really resonates. We do Medicaid crosswalk analysis, where we look at the services that are currently available in Medicaid that connect with supportive housing, so that we can see, one, make sure providers are accessing what the state can already do, because sometimes you're missing out on the things that you could be billing for. And then two, seeing where the gaps are. Because there are so many options in the Affordable Care Act, there's no one fix. There are lots of ways that states could take advantage of the Affordable Care Act for our folks. And the crosswalk kind of shows what the gaps in services are, and then can inform whatever the state decides to do. We're obviously engaging supportive housing providers because billing Medicaid is not easy, and it's not something everybody wants to do. So we want to make sure that we pick the right supportive housing providers that want to bill Medicaid on their own, but then also help supportive housing providers make partnerships with people who could bill for the services on their behalf. We're engaging managed care networks, as I said, and and first on the list is making sure that we're meeting the needs of tenants and their satisfaction. Denver's did a great job of doing a survey of residents of supportive housing to gauge what their access is to the healthcare system, and they're using that to inform the changes that they need to make. So with that, I will pass it on to Rich.
Thank you, Peggy. I did kind of a short introduction for the speakers. I wanted to give a little bit more background right now. So I really want to recognize Peggy's role. She is seen as a national leader in this movement to try to integrate healthcare systems with the field of supportive housing. Her title is actually the Senior Policy Advisor to the Corporation for Supportive Housing. I actually had the honor of working with Peggy. We both used to work at the National Alliance to End Homelessness in Washington, D.C. before she went to the corporation. At the National Alliance, she served as the Behavioral Health Policy and Program Analyst. She also served before that as the Senior Healthcare Financing Policy Analyst for the Association of Maternal and Child Healthcare Programs. So she has over 15 years of experience in this field, and she really is setting the agenda in a lot of circles in a lot of states, so I really appreciate her making time to come here today, so thanks, Peggy. I just want to say that my role is I'm an attorney in the state of Minnesota, and I'm also a homeless advocate, and I'm a nonprofit director. And the nonprofit that I direct in Minnesota is called Hearth Connection, and we are a statewide organization that does supportive housing. I work with populations that experience long-term homelessness, so my populations tend to be individuals, families with children, and unaccompanied youth that have at least been on the streets or in homeless situations for more than a year. Typically, our single adult population comes to us with over 8 years of homelessness on average. That's their average length of stay in homelessness, is 8 years or more. And what my program does is we created a network of regional collaboratives to expand the supply of supportive housing. And the reason I want to say that is that as a nonprofit director, not as an attorney, of course, my role as a director is to generate revenue for my program to continue to expand the supply of supportive housing. And the supportive housing and homeless services field for much of the last 30 years, has primarily relied on federal grants, state grants, and foundation, private philanthropy, right? Those are the kind of main funding streams in order to create services for people that are experiencing homelessness. And what we're trying to do now is to say that because healthcare is such an integral part of homelessness, that as Peggy was saying, that for our populations, housing is such a pivotal role in achieving healthcare outcomes for those individuals, that without housing we will not achieve positive health outcomes, that we need to find a way to integrate healthcare systems with housing. And we need to integrate healthcare financing with housing. And the difficulty with that is that these nonprofit providers are not used to doing that. They're not used to hearing medical terms or billing MA or becoming licensed providers for MA billing. And it is a cultural change. And that's why I wanted to bring this workshop to today's continuing legal education courses, because I think there's a role in the bar to play in helping to educate the nonprofit sector on the opportunities to use Medicaid funding to actually expand services in your community, but also to facilitate that dialogue. The nonprofit communities probably by themselves won't come together unless there's somebody helping them to facilitate that knowledge. And I think the bar has the opportunity and the responsibility to identify leaders in your local areas that are experts in healthcare law or experts in disability rights and experts in Medicaid to come and talk about the options that are available. As Katie was saying, this isn't a mandate. We're going to have to advocate for this either through the administration, your executive branch at your state level, or in your legislature. But it is possible, and I want to give you a sense of hope. So my role is to kind of give you that framework, but also to give you the example of what my project did to integrate Medicaid funding into our supportive housing field. So I think as I said earlier in the session today, this is supported by the ABA Commission on Homelessness and Poverty. The Commission is dedicated to educating the bar and the public about homelessness and poverty and the ways in which the legal community and advocates can assist those in need. Amy Horton-Newell is the director for the Commission, and she's in the back of the room. I'd like to acknowledge her. She's been a wonderful resource for the Commission for many years, and I have our website at the bottom of that PowerPoint page as well. If you haven't heard, probably everyone here has, but there is a federal plan to end homelessness. It was started in 2008 with the President Obama's administration, and it's being coordinated by something called the United States Interagency Council on Homelessness. The federal plan is called Opening Doors, and there's the site to it, and it says in the plan, quote, "The most successful intervention for ending chronic homelessness is permanent supportive housing." It's the first time that the federal government has actually, in a very concrete way, recognized an evidence-based practice and begun to develop resources to support the expansion of it. The goals of the CLE are to build skills, offer opportunities for lawyers to involve themselves in local planning efforts to expand Medicaid resources, and implement Olmstead, which is what we're going to hear in the last part of the CLE, to increase the supply of supportive housing. Hearth Connection, my project in Minnesota, is a statewide organization. We manage 3 regional collaboratives, multi-county collaboratives. So in the state of Minnesota, there are about 87 counties, and I organized about 45 of them, almost half of the counties, into 3 regional collaboratives. We are an intermediary, which means that I, as an organization, do not provide direct services. I don't own housing. I don't deliver services. Hearth Connection has the role of taking complex federal and state funding streams, bundling them together, and then subcontracting them out to other providers on the ground to expand supportive housing. So I work with over 28 different nonprofits and 3 American Indian tribes in the state of Minnesota, and we serve over 1,300 people each year, both children, adults, and youth. We believe that permanent supportive housing breaks the cycle of homelessness and achieves housing stability and health recovery. As an organization, we tend to be a data-focused organization, and we have a very sophisticated database that we track all of our participants, not only on their housing stability, but also on 17 different domains of individual functioning. So as Peggy was saying, when we think about supportive housing, when I think about supportive housing and my role as an intermediary to pull down 2 pots of money in order to make it work. One pot is supportive services, so the money it takes to pay for a case manager, a social worker, to work with the participant in a housing context. And the other pot of money that I struggle with is rental assistance. Unlike what Peggy focused a lot of her remarks on, which was talking about building and capital, my model is what they call a scattered site supportive housing model, which means that our providers don't typically own buildings. We have rental assistance vouchers that we give to participants, and they go and find apartments that they want to rent. And as long as we can convince a landlord to engage with them and rent to them, they can choose where they want to live in what neighborhood. So the two pots of money I'm always struggling with is where can I get enough rental assistance so people can have more housing, and where can I get services money in order to bring people to engage with in a trusting relationship and work on a case plan with these people. Typically, through our funding mechanisms, we've pulled down multiple sources of funding in order to make that happen. On the supportive services side, I've pulled down state funds, something called the State Long-Term Homeless Supportive Services Fund. I've pulled down federal dollars called the HUD Supportive Housing Program grants, and I've utilized already Medicaid targeted case management services. So even before healthcare reform, Obamacare, and the ability to look at Medicaid in a new way, the state of Minnesota had a program where you could pull down dollars to pay for targeted case management services. But in order to get that service, the person needed to have a serious and persistent mental health diagnosis. And of course, not all of our participants have mental health disabilities. Some are addicted to chemicals or alcohol, and some are simply just poor and are homeless. Does that make sense? And they didn't always receive eligibility to receive Medicaid TCM. But for those that did, TCM provided a per month rate that we were able to pull down. It didn't cover the entire cost of case management, so we took the targeted case management pot of money and we supplemented it with the state and federal dollars to pay for the total cost of case management. But because we were pulling down these federal dollars, we were able to stretch those state dollars even further. Does it make sense? Instead of having the state dollars cover everything. The rental assistance portion of our financial package is typically HUD programs, supportive housing program, and shelter plus care, as well as a state housing trust fund that we pull down for rental assistance. So what we do is we are trying to, our goal as Hearth Connection now is to link health systems with supportive housing. We will continue to target chronic homeless populations, and we try to serve what we term as the hardest to serve populations. Those individuals that have multiple and costly public system involvement. So people that are seen in jails, detox, emergency rooms, hospitals, child welfare, you know, the list goes on. But if we have those individuals that are being seen multiple places because of their histories of long-term homelessness, those are where the wins are going to be when we're able to stabilize them. Our program, however, is a voluntary program, so much like the foundation of permanent supportive housing, the services are voluntary. We don't force services on our participants. We avail them to them so that when we give them a housing voucher, we say, here's your apartment, and if you'd like to work with your case manager, please do, but you don't have to. We are a harm reduction program, which means that we focus on reducing the level of harm experienced by our participants. We typically do not require sobriety or abstinence or any type of treatment. And we're focused on housing stability and healthcare recovery. The hook for us in trying to integrate healthcare systems was exactly what Peggy was saying, cost. If we can show to the healthcare systems that investment in our services and our housing will reduce down their health system costs, then we have a win-win. Our first jump at this was a hospital program called a hospital to home pilot, which we did at one hospital in St. Paul, Minnesota with just 7 people. It was very tiny. But we had the emergency room doctors identify the 7 individuals that they saw again and again and again that they thought were homeless. We identified them, and then we provided them with supportive housing, and we tracked their outcomes for 2 years, pre-entry into our program and 2 years post-entry. What we saw was an 81% decrease in emergency room use in the 2 years following enrollment in permanent supportive housing. That is a great cost win for that hospital. Does that make sense? Because this was a county hospital that in many times was having to pay for emergency room costs because it wasn't being reimbursed. Clinic use also decreased. Participants accessed medications more consistently, including stabilizing their pharmacy claims. And 5 participants experienced at least 1 inpatient hospital stay prior but only 2 had hospital stays after enrollment. So we not only decreased the emergency room, but we also even decreased their enrollment in inpatient hospitalization as well. So that was a win for the hospital, and they're continuing to do this partnership with us. So I want to talk to you about Bill. He was one of the participants in that pilot. He was an adult male in his late 40s. He had been homeless for 2 straight years. He had been sleeping on the streets on trash bags full of clothes. And if you know anything about Minnesota, we get a little bit cold. And so that is a vulnerability, it's a huge vulnerability. He wasn't coming indoors to shelter even during the worst months of January and February. He had chemical addiction and mental health disabilities, and he was a frequent user of the ER room and hospitalization when we enrolled him in the hospital-to-home pilot. The outcome was that he has lived in stable housing for over 3 years. He visits now a primary care physician monthly. He reduced his emergency room visits from 18 visits in 2009 to just 4 in 2011. He's working on his personal goals to maintain sobriety and reduce his weight. And he was working as a part-time sales representative for over a year. So that's just giving an example of kind of what we were able to do with just one of our participants. Again, part of what we do is we pull down Medicaid targeted case management services. These are federal Medicaid dollars. The challenge was that there is a match. You have to find a match for local communities. So it's not just all federal dollars. There's a partial local match with targeted case management. And in the way that the formula ran out in Minnesota, it was almost equal 50-50. So an example of is that if I have a cost of $1,000 per month to provide services to a participant, and I was getting $800 in targeted case management services, $400 from the feds, and $400 from state, then I supplemented that with another $200 from the state, and that's how we were able to do this financial package for this targeted case management. The limitations, I think I've already said, of this targeted case management system is that it requires a serious and persistent mental illness diagnosis. There is a cap on the number of people that we can enroll by the county regulations, so we couldn't just enroll everybody that we thought we could. There is a requirement of special reporting for that program. It doesn't cover some services delivered. So here's a service that the case managers do. They find a landlord, they help you negotiate with the landlord, they help you move in. That's not a targeted case management service. Does that make sense? That is a tenancy support, and that can't be billed. Does that make sense? But the case manager still needs to do it in part of this package. It is administratively burdensome because of their financial record keeping, and again, it doesn't cover the entire cost of case management. So then, the heavens opened up in Minnesota. Healthcare reform happened, and Minnesota became an early adopter of Medicaid reform. We became an early adopter of the Affordable Care Act. And I won't go through this because Peggy spent a lot of time on this. But just know that Minnesota became an early adopter, and what that did was it changed the viewpoint that Medicaid was only for people that were poor and disabled to now you just had to be poor. So my participants who were homeless and poor now are eligible in Minnesota for Medicaid, for medical assistance, where before we had to prove that they had a disability. So that's been a huge, so now I can think about all kinds of ways that I can try to pull down Medicaid dollars for my entire population, because all of my population, long-term homeless people, are poor. Boy, that's fancy, I love that. Okay. So what we did was I want to talk to you about a managed care option. She talked about managed care, so health plans in Minnesota. Minnesota uses managed care organizations to finance and deliver health care to Medicaid members. So the health plans get a whole bundle of people given to them, and they're told, here, you serve these 5,000 people under your health plan, and here is your rate in order to do that. The Medicaid members enrolled can opt out of being under the health plan. They don't need to stay with that health plan, but they need to opt out. They're opted in and they can opt out, which means that there was this large influx of people in the last year. There is a capitated rate, again, for each individual. Our pitch to the health plans in Minnesota was that permanent supportive housing was cheaper than continued frequent use of emergency rooms and health hospital care. And then, like Peggy was saying, if we can convince them, just like in Massachusetts, if we can convince the health plan that investing or purchasing our services reduced their cost, it was a win-win. So we started something called the Medica Supportive Housing Project in the Twin Cities. Medica is the name of a health plan in Minnesota, and we negotiated with them. The Medica Supportive Housing is an initiative that will offer participants supportive housing designed to achieve housing stability, improved well-being, and decreased reliance on emergency and inpatient medical care. It's a smaller project again, but it actually serves up to about 90 people, 85 in our largest cities of the Twin Cities in Minnesota, and 5 people in a rural city called Duluth up on Lake Superior. The target is frequent healthcare users and long-term homeless people. These are very low-income people. They have chronic health conditions. They are long-term homeless and are high utilizers of crisis health care. They are either single adults, parents with children, or unaccompanied homeless youth, and they are individuals who require support in order to maintain housing and achieve health or functional recovery. Our permanent supportive housing model is an essential component, including intensive case management services, housing first, which means that we will take you right off the streets. We don't require you to succeed in shelter. We don't require you to jump through transitional housing first. We take you right from the street and give you your apartment keys. We're harm reduction, we're a trauma-informed service, and we organize our work around mobile collaborative teams. So we actually, not only do you have an assigned case manager, but that case manager is a part of a mobile team of other professionals that you can access. However, the thing I want to point out is that this model is distinct from care coordination. So part of what Peggy was talking about was that the health plans want to coordinate health care. They want to care coordinate. And what I'm talking about is purchasing case management services and delivering that in the context of a supportive housing program. There are different roles. Our role at Hearth Connection is to secure and distribute funding for services. We are to get the funding for rental assistance. We are to offer financial oversight and programmatic administration of the project. We implement orientation and training for these case managers, and we maintain our database and collect and analyze data. And we ensure fidelity to our service model. The community agency that we subcontract with, they offer intensive case management services, and they partner with participants to achieve results in rapid access to affordable housing, improved well-being, and lower utilization of emergency health treatment. There is a commitment to the collection and entry of data, and they also have fidelity to our service model. The health plan, of course, identifies participants in their health plan to refer to us. They actually wrote an algorithm to identify very high-cost users of their systems, and then gave us that list in order to find those individuals. They deliver care coordination services. They share data on their participants in an aggregate way, and they also help us in doing data analysis and research. But most important from my perspective, of course, they're paying me. They purchase the services. So I have a multi-year, 3-year contract that can be extended up to 7 years in order to house and serve these 90 individuals. The project goals are to achieve housing stability, improve health, improve access to primary health services, and to decrease healthcare costs. There is a research and data analysis staff dedicated to this project, and it is a 3-year research initiative. So the future now is that now that we're implementing this project, we may want to look at other things that Peggy looked at. So this was just a pilot from a managed care, but we may want to look larger in Minnesota. So we're considering things like a 1115I state Medicaid waiver, a 1915I state Medicaid plan amendment, or looking at how we can partner with something called behavioral health homes, which is what Peggy just touched on a little bit. So these are all things in the mix, and what I'm just telling you is that this managed care project that we're doing is just one of many things we're trying to do to integrate healthcare systems. This is my contact information. Feel free to contact me in Minnesota anytime you wish. If you have questions about my project, I just wanted to give you kind of a viewpoint of boots on the ground and how it works in kind of using Medicaid to support services in supportive housing. Go ahead. You want to say something?
No.
Oh, thank you. So now I'm going to turn it over to Pam Cohen. Is she here? Elizabeth first, okay? So Elizabeth Zerker is a staff attorney with Disability Rights California in Oakland. She works on class action Olmstead litigation, which has challenged the state's planned elimination of adult day health care, and also works on deinstitutionalization of residents at the Laguna Honda Hospital in San Francisco. Her main focus is on improving opportunities for people with disabilities to live in the community, including Medi-Cal home and community-based waivers. We're glad that Elizabeth can come today to talk to us about Olmsted and its implications for people with disabilities and expanding the role of supportive housing as well. Thank you, Elizabeth.
Thank you. Good afternoon. I guess you could go to the first slide. Thanks. So we just wanted to start today. Pam and I are going to be co-presenting, but this is legal framework for what we'll be discussing. Americans with Disabilities Act and Title II, which was interpreted by the Supreme Court in the Olmsted decision, as well as Section 504, which governs housing which receives federal funds, the Fair Housing Act, the Federal Fair Housing Act, and of course relevant state laws in California. It's the California Fair Housing and Employment Act, which is also known as FEHA. So many of you may have heard of or know the Olmsted decision, but it's a Supreme Court decision, 1999, a seminal decision which involved two women with mental health and developmental disabilities who were in a state-run institution. They had entered there voluntarily, but after some time decided that they'd like to leave and live in the community. And the state officials determined that they were, in fact, capable of living in the community with supportive services, but the state said that they didn't have to provide those supportive services under the Americans with Disabilities Act. And the court found that, in fact, unnecessary institutionalization is a form of discrimination under the Americans with Disabilities Act, and that the state was required to provide services in the most integrated setting that could meet someone with a disability's needs. And so this is also known as the Olmsted Integration Mandate. And essentially, Olmsted requires that people with disabilities be served in the community when they prefer to be served in the community, when it's been determined that they can be served in the community, and when providing services in the community can be reasonably accommodated. So, of course, there's got to be a limit, right? And so the defense to an Olmsted claim is the fundamental alteration defense. And essentially, states and public entities are required to make reasonable modifications to their programs, but are not required to make a fundamental alteration. And this slide is sort of is a quote from the Olmsted case about what is a fundamental alteration. Obviously, this is the source of much litigation in terms of what the state can say is a fundamental alteration. Courts have found that it's not a fundamental alteration to ask to make changes to financial and other eligibility requirements. Additional expense to the state is not necessarily a fundamental alteration. But the other piece of Olmsted is that states can show compliance with the integration mandate and with the Olmsted decision by having a comprehensive plan, a comprehensive, effectively working plan, and if there's a waiting lists need to be moving at a reasonable pace. What this has done is that most states have, in response to Olmsted, which is 14 years ago now, developed Olmsted plans. And this is somewhat of a double-edged sword because on the one hand, a state's implementation of a good faith plan shows that they're trying to provide people with disabilities services in the most integrated setting, and it should be doing so. And on the other hand, the existence of Olmsted plans has been used as a defense in litigation. So I wanted to focus my part of the presentation today on our Laguna Honda litigation, and there have been two lawsuits that our organization, along with co-counsel, have filed regarding Laguna Honda Hospital, and more information about both of them and pleadings, et cetera, is available on our website. Next slide. But Laguna Honda, to give you some background, Laguna Honda is the largest publicly owned nursing facility in the country. It was founded in 1866 as a poorhouse, and at the time of our first litigation, which was the Davis case, and which was in 2000, there were approximately 1,200 people who were living at Laguna Honda. Many of the people who were living at Laguna Honda were formerly homeless individuals who had had some kind of injury or medical event which led them to need skilled nursing care. And the fact of their homelessness and the fact of the city's over-reliance on this institution meant that many of them just ended up staying there for many years. And one of the Department of Justice investigated Laguna Honda for a number of things, including in 1999 and 2003 issues with rights in the facility and quality of care in the facility. For instance, the building, which has now been rebuilt, had open wards, so people would live 37 beds to an open ward, separated by curtains. We had one of our named plaintiffs had been there 30 years. So people lived like this for 30 years, and it was known as the Florence Nightingale model of nursing, which was supposed to be a very efficient way to deal with a lot of people in one setting. You have the nurse at the end of the ward, and she can eyeball everybody, all of the beds down the row. But obviously, this is hardly an integrated setting or a decent way to live, really. So state and local and federal funds all pay for Laguna Honda. So that 95% of the people who are at Laguna Honda are Medicaid recipients, which is Medicaid in California. The facility also, and this kind of goes to what Peggy was speaking about before, I'll talk about it a little further on, but the facility is licensed as a distinct part nursing facility, which means it has a few acute care beds. And it means that the daily rate for services there is much higher than in your regular nursing facility. So one of the cost pieces for both of our lawsuits was that it was about $310 a day for the distinct part Medi-Cal rate. But because having such a large institution, you can't really, it's never cost effective. The budget has ballooned over the years, even as the census has reduced. But in any case, San Francisco was subsidizing with general fund dollars that could go anywhere in their budget. They subsidized $120 a day per person at Laguna Honda. So the cost of care in about 2006 was $500 per person per day to be in this facility, living in an open ward setting with your bed and a little chest of drawers next to you. And I'll also just, about the population, it's generally a much younger population than you would think of for our nursing facility. So many younger people with disabilities and, as I said, homeless. I mean, people who were homeless, except they weren't getting counted as homeless because they were at Laguna Honda. Now they have a petting zoo. So the 2004 settlement in the Davis case developed a number of things. The Davis case was filed in 2000. We reached a partial settlement in 2004, and that involved the assessment and discharge planning for everybody at the facility. And it also involved the city setting up a targeted case management program to do the assessment and discharge planning for people at Laguna Honda. So targeted case management was available in San Francisco for only Laguna Honda residents and for the purpose of assessing them, figuring out what they would need to leave, and developing discharge plans for them. We didn't get to the piece of once you have that discharge plan, what's going to happen with that plan? Where are you going to go? Are you going to leave Laguna Honda? And what we found in after a few years was that the targeted case management assessments had determined that up to 80% of the people who are at Laguna Honda could leave with services, and over 50% preferred to leave, but they were not leaving, primarily because of the lack of supportive housing, and the lack of accessible, affordable housing, and the lack of the kinds of packages of services that people needed, because we're talking about individuals with, many of them had co-occurring disabilities, many of them were people with mental health disabilities, people with substance abuse, and also people who had complex medical issues as a result of, many of whom as a result of accidents, who had been at Laguna Honda for rehab and remained there, but had never lived in the community as a person who used a wheelchair, for instance. So there was a lot of kind of complex services that they were going to need in the community. And so we filed the Chambers case in 2006 and reached a settlement in 2008. And the Chambers case, both of these cases were Olmstead cases, were alleging unnecessary institutionalization. But the Chambers case set up a diversion and community integration program, which was a collaborative group of providers, city service providers and facility providers who look at each person and determine what kinds of services they would need to leave the facility. Access to a city-funded community living fund, which is a sort of catch-all fund which could pay for a number of different things for people leaving Laguna Honda. And then the Laguna Honda Hospital Rental Subsidy Program. And that subsidy provided for the city paying up to $1,000 in a subsidy to someone who then would pay a portion of their own Social Security income, and use that to find housing in the community. On the website, there's a copy of the request for proposal that the city put out for the contractor who ultimately runs that subsidy program. That's this agency, West Bay Housing, which is a really great organization that essentially went out to landlords in the community, different buildings, and acted as the go-between, so that people who would get the subsidy would be able to have the assistance of West Bay to help them secure the housing, help them with any evictions that were in their past, which might have been a barrier for them to be accepted into housing. That in combination with the home and community-based waiver that one of the waivers that is available in California was allowed people to move into the community with services. And that waiver, let's just follow up, it's a 1915C waiver called the nursing facility / acute hospital waiver. And the significance of this distinct part rate comes into play with this waiver, because the way that a nursing facility waiver works essentially is you take the money that would be used for you in the facility and you purchase a package of services from the menu of services in a waiver, and then use those in the community as long as you stay within your waiver budget. And so with the distinct part rate, people leaving Laguna Honda have a budget of about $78,000 to pay for all of their services, including personal care services, case management, habilitation. And this makes that waiver really usable, because in California, unfortunately, there's this waiver which is theoretically great, but unless you're coming out of a distinct part nursing facility, the rate is generally, if you're a nursing facility level A, they give you $35,000. If you're level B, they give you $48,000. But if you're somebody who needs more than 8 hours a day of personal attendant care services, those budgets don't really work for you. But if you need more, that $78,000 can really get you a robust set of services, which in combination with the subsidy program has been a really effective model. Go ahead. So this is not our case. This is another case. It's in New York, and it just there's a settlement agreement that just was reached, or is about to be reached. The settlement is online now. It just did. Okay. In this case, which was formerly known as DAI versus Patterson, but it involves people with mental health disabilities who are living in adult homes in New York, and the state of New York was paying for services in these institutional adult homes, and you can go to the next slide. The settlement now is providing for as many scattered site housing units as are necessary in combination with services. And I wanted to mention this case in particular because I think both that scenario and the scenario in San Francisco involve situations where the public entity was providing for housing already. It just was providing for housing in non-integrated settings. Because one of the things about using Olmsted to get housing is that you really have to look at the big picture of services that the public entity is offering. Because the fundamental alteration piece is if you're asking the state to create all kinds of new programs that don't exist at all. In San Francisco, we were able to show that the city was essentially subsidizing the housing piece of people that lived in a Honda, had an existing infrastructure that they could spend their money on, but were not spending their money on. Because they had this giant institution, it sucked up all of the community-based services. And I think the same, they're not obviously exactly the same scenario, but if you look at the adult home cases, the state was already paying for people to live in these homes. They just weren't in integrated settings and didn't comply with Olmsted. So that's something to be thinking about it as you think about your own Olmsted litigation and think about housing as a remedy. And then the last thing before I turn it over to Pan is that there's been a recent report by Senator Harkin on what's going on with the implementation of Olmsted across the country. And it's not particularly rosy. And the recommendation is that that there should be a national action plan to expand access to affordable, integrated, accessible, and scattered site housing for people with disabilities, consistent with Olmsted. But it's a pretty interesting. If you just Google July 2013 Harkin report, it's not in the materials, but you should be able to find it pretty quickly, and it's very interesting and goes state by state, gives some fascinating numbers about what's happening in various states, and I would recommend taking a look at it.
Thank you, Elizabeth. Pam Cohen's now going to speak. I just wanted to say that she's also a staff attorney with Disability Rights of California. Before that, she was an independent consultant focusing on the legal and policy issues related to community-based care for older adults with disabilities. She's also been a court-appointed criminal appellant defense attorney, a staff attorney with the Bazelon Center for Mental Health Law in Washington, D.C., and a project manager for AARP. So we're going to learn, I think, a lot from her today, and I really appreciate her time as well, so welcome.
Thank you, Rich. I get to be the last speaker on Friday afternoon. Feel free to pass the chocolate around again. I'll try to keep you awake. Very quickly, my role at Disability Rights California is that I represent adults with mental health disabilities in all different kinds of settings and on all kinds of different issues. One of them involves housing discrimination. And my hat that I'm wearing today is under a grant from the California Mental Health Services Administration. I'm writing a policy paper on overcoming neighborhood opposition to supported housing for people with mental health disabilities. So I'm in the research phase of that and interested in input from anybody who has faced those issues. So I'm going to talk about administrative guidances that have come out recently about the Olmstead decision. For those of you who took my approach to administrative law in law school, which was to skip it entirely, I just want to say that administrative guidances are just guidances. They're not binding, they're educational, they're there to help housing authorities, in this case, providers, housing providers, service providers, advocates of the public, in this case on how these agencies think that we should be implementing the Olmstead decision. So there's two that we're going to talk about. One is the Department of Justice guidance, and one is, and one is the HUD guidance. The Department of Justice guidance was issued in 2011, and it has a few highlights. I'm just going to go over these pretty briefly. They're listed here, but I won't go through them right now. I'll just do them one by one. The first one is that it elaborates on the role of public entities in implementing the Olmstead decision through the provision of integrated housing. And really, what it's doing is showing DOJ's emphasis on getting Olmstead implemented in the states. Olmstead really has DOJ really has stepped up its efforts on this in the last few years. I don't know if any of you caught it, but the PBS NewsHour did a segment on this just like Wednesday night, I think it was. And Jennifer Mathis from the Bazelon Center was very eloquent about this. It's worth catching if you can, it's online. So it talks about a lot of what Elizabeth was saying, that remedies for Olmstead violations typically require the public entities involved to expand the capacity of community-based housing. It sounds obvious, but the fundamental alteration defense has been used in all kinds of ways, and this guidance is trying to say, it's kind of trying to limit what the fundamental alteration defense is, and just emphasize the importance of community-based care as an Olmstead remedy. And it goes so far as to list examples of what the actual remedies would be, similar to the litigation that Elizabeth was talking about. She showed you exactly, what we actually have gotten as remedies. These are examples that DOJ is giving of what could be remedies, and they include a lot of the same things. And then it says the same thing in the other direction, which is that a public entity can violate Olmstead by not doing these things. Basically by operating facilities that are segregated, meaning, well, we'll talk a little bit about what segregated means because it's not entirely clear, but generally it means having people with disabilities all in one place together without being integrated with people who don't have disabilities. Or financing that, or promoting that through their financing systems or their planning systems. So, and this is of course related, the guidance clarifies that a state budget cut can constitute an Olmstead violation. When it creates a risk of institutionalization or segregation. And it says that a service, in order to count as a community service under Olmstead, actually has to exist and be available for real and not just on paper. And that states' Olmstead obligations are separate from their Medicaid obligations. So for example, if you have a Medicaid waiver where there's a cap on the number of people that you need to serve under the Medicaid rules, you may still need to serve more people under your Olmstead obligations. This next one has been articulated in litigation, but it's emphasized again in this guidance, that the relevant resources for determining what is available to a state under the fundamental alteration defense is all the money that the public entity allots, spends, receives, or could receive if it applied for available federal funding to provide the services to people with disabilities. Not just the amount of money that the state chooses to spend or the grants that the state chooses to apply for the federal government. And these are all issues that have been litigated about, like, what does cost mean? The DOJ is telling us that cost comparisons are not static, so you have to look at how they change over time as the state's transitioning from an institutional model, hopefully to more of a community-based model. Transitional costs, such as if you have a hospital that has to remain open but not fully populated while you're emptying people out into the community, there may be transitional costs where you have duplicative services. The state can consider those, but they can't, it's not determinative. The state can't say, oh no, it's just too expensive because there are going to be these years here where we're going to have parallel systems. And the cost of backfilling are not considered, meaning if you can't, the state can't take those empty hospital beds and put more people in them and then use those costs. You actually have to empty those beds out. So more about budget cuts, emphasizing that the state just can't say, oh, we have a budget cut, we can't, create community services. They really want, the Department of Justice really wants courts and states to look behind that and see what they can do. Entities can still make more cost-effective measures, even if they're having budget cuts. They have to make sure that they're acting efficiently, even within the budget cuts, and seeking the sources of funding that they can seek. So another one of the highlights of this guidance is just the emphasis of the effective, comprehensive, effectively working Olmstead plan, so Elizabeth was talking about. And then the last one is consumer choice. And we can skip this slide, go to the next one. I really like this quote. This really is my experience working particularly with older adults, that's mostly my background. People who've been institutional and segregated have often been repeatedly told that they're not capable of successful community living and have been given very little information, if any, about how they could successfully live in integrated settings. As a result, individuals and their families' initial response when offered integrated options may be reluctance or hesitancy. That, combined with the fact that there often aren't community-based services for them to look at, means that the choice that people are making is not very well informed. And this was my experience working in Washington, D.C., trying to close their big public nursing facility there. Our biggest opposition was the family members who were so risk-averse. They didn't want their family members to leave because they didn't know where they were going to go. And we had a really hard time trying to get them on our side to try to make that transition. So I think this is a really important thing that the Department of Justice is saying here. So then they go on about how to take affirmative steps to remedy that, and specific examples about providing information about community settings. That just often has, I mean, my experience with this is a little bit old, actually before Olmstead itself, but I think it just often doesn't happen, that people are really given good information. And given taking the time to really explain it in the way that people and their families can understand it. People both, and their families, both the residents and their families, and it's important that both happen. Facilitating visits to community settings and offering opportunities to meet with people who live there and work there. And then addressing concerns and taking affirmative measures to see if there are concerns. This doesn't sound like it's such groundbreaking stuff, but it really is. And this is the Department of Justice, who has been actively involved in cases like the DAI case, saying what really we should do. This is not necessarily what does happen all the time. So now we'll go to the Department of Housing and Urban Development guidance, which is brand new, just from June of this year, and a little confusing. Okay. I'm going to lose you here, I guarantee it. Okay, so we'll start off easy. It talks about a lot of the same things that the DOJ guidance talks about, with consumer choice and autonomy and expanding alternatives, and that's all very nice. Then it goes on to confuse everybody. Okay. Encouraging public housing authorities and other HUD-assisted housing providers to develop integrated housing. That's nice. This is where it gets to, we get complicated, discussing the legality of disability-related housing preferences. So the first one is easy. Public housing authorities and other HUD-assisted housing providers should develop housing that's integrated, with a particular emphasis on scattered site housing, which Rich talked about a little bit, which is sort of a newer model, where we don't want our community settings to turn into institutions. We don't want these big, huge places that look a lot like the institutions people came from. Okay, now, onto the disability preferences. Is it okay to give housing preference to people with disabilities over people who don't have disabilities? Yes. But is it okay to give housing preference to people with certain types of disabilities over people with other types of disabilities? We're not sure. I'll explain that, but don't expect an abundance of clarity here. So the easy part is that local preferences for people with disabilities, housing preferences for people with disabilities over people who don't have disabilities is allowed. It's fine for two main reasons. One is that the fair housing laws give people with disabilities the right to equal access to housing and require that housing be provided in the most integrated setting in accordance with Olmstead and that whole, principle. And the fair housing laws do not protect people who don't have disabilities. There's no such thing as reverse discrimination. You can't bring a claim that you were left out of the housing preference because you're not covered if you don't have a disability. So that's not a problem. The problem comes with disability-specific preferences. Having a housing preference for people with a particular type of disability over people who have a different type of disability. So this quote here is what the HUD guidance says, the brand new June 2013 HUD guidance. Public housing authorities and other recipients of HUD assistance may develop local preferences for people with specific types of disabilities only as HUD-approved remedial action or as specifically authorized by the Section 811, Federal Section 811 supported housing program. That's what it says. The site down at the bottom here is, in addition, is other things you could look at that say something similar, older HUD memos. The next slide is the actual quote from the guidance, because I wanted you to see the actual words. So these preferences can be authorized in connection with remedial actions under DOJ enforcement, Olmstead-related settlements or litigation, and state and local governments' voluntary documented affirmative Olmstead planning and implementation efforts. These remedial actions have to be authorized by the HUD Office of the General Counsel's Office of Fair Housing. So it's not like you can just say something's a remedial action. HUD actually has to authorize it as such. And public housing authorities also have to request a waiver of HUD's program regulations precluding disability-specific preferences. So this isn't like an official thing. The guidance says HUD is working to streamline the approval process. I don't exactly know whether that means streamlining the process of approving a remedial action or streamline the process of getting those waivers approved, but the people I've worked with have never seen a HUD process that didn't need streamlining. So that seems like an admission to me that, yeah, well, we might be a little bit slow about this. And another way, the only other way, according to this guidance, to have a disability-specific preference is to have it specifically authorized by this particular Section 811 program. So, on the other hand, there are HUD and there are, 504, Section 504 and Fair Housing Act regulations that specifically allow and sometimes require disability-specific preferences in circumstances that are not covered by the HUD guidance. So the charitable interpretation is that the HUD guidance just doesn't apply to everything, but really when you look at it, it looks like a conflict. And it's just too new to have been worked out. So these are some, the next few slides are some, let's see what, yeah, I should get through this. So I'm not going to go through these particular regs in any detail, but you should just know that the Fair Housing Act regulations, which apply to private housing providers as well as federally assisted housing providers, require owners of housing projects to take reasonable steps to maximize the utilization of accessible units. So if you have physically accessible units in your building, you have to give tenants who need that accessibility priority. So that would be, for example, a physical disability over a psychiatric disability, if you need the wheelchair ramp or whatever. And housing providers are allowed to make disability-related inquiries to determine whether an applicant is qualified for a dwelling or a priority available only to persons with a disability or with a particular type of disability. So that kind of foresees that there are these preferences. There's a typo, by the way, in that slide. If anyone gets to this point, the last slide should be 24 for CFR 42C. And then also the Section 504 regulations, which apply to federally assisted housing, says that you can't provide a disability preference unless it's necessary to provide qualified individuals with handicaps, which is the language in the law, with housing, aid, benefits, or services that are effective as those provided to others. So that, again, foresees that there are going to be disability-specific preferences. And then there are specific programs that aren't the Section 811 program that's mentioned in the HUD guidance that also tell you that you have to have disability-specific preferences. For example, the home project that's listed here. So that's clear as mud. I can't really make it any clearer. It's an issue, and we're going to have to see how it works itself out. There are, what we have done is sort of conceptualize it a little bit in terms of what the policy considerations are here as this gets worked through. And I think it's kind of helpful to look at it as two different questions that are related. One is, how do we allocate scarce federal dollars? So that has mostly to do with if you look at the 504 regulations, which apply to federal assisted housing, and HUD making guidance about how you can use HUD dollars, do we want to use those for disability-specific preferences or don't we? And another issue is under the Fair Housing Act, do we want to prevent housing providers from making these disability-specific preferences by calling them discriminatory? And a lot of this has to do, like both of those questions, has to do with integration versus consumer choice. A lot of consumers do want to live in housing that does not include a disability-specific preference. That would be scattered site housing, where it's an apartment in an apartment building with a lot of other people, and there's may not be services right there, but there are services available, and then it's not an issue. But there are people with disabilities who want to live in what we are calling more segregated settings, in that they want to live with other people in congregate settings, and sometimes they want to live with people who have disabilities, and that's just how it is. And so to really maximize consumer choice, we should have all these options available. And one example, which I guess we really don't have time to talk about a lot, but it's worth Googling, is the Apache ASL Trails housing situation in Arizona, which is really interesting. It's a home that is targeted to deaf people who use American Sign Language, and it is accessible in a way that's made for deaf people. It's got flashing lights and intercom systems that work for visually and things like that. And the preference is for people with, who are deaf who use ASL, not just people who are deaf, but people who use ASL. And most of the people there are. And HUD is challenging that preference. And the deaf community is up in arms about it, and it's going to be very interesting to see how it plays out. So I'll stop there.
Thank you. So we've come to our point where now we're opening it up for dialogue or questions. What we'll try to do is, since there's not mics out there, we'll try to, if you position a question to any of us, we'll try to repeat the question back and then answer it. So what questions do you guys have? Yes?
The first two speakers talked a lot about how supportive housing would, bring about reductions in medical costs. But the second two speakers didn't. Is that because you've already incorporated that the homestead thing would also reduce medical costs?
Can you repeat the question and answer? I think it's for those two.
I think the question was Rich and Peggy had talked about supportive housing reducing medical costs, and that Pam and I hadn't really addressed it. It was not. It was actually part of the Laguna Honda lawsuit that it would be cheaper to serve people in the community. Absolutely. I mean, part of that was how expensive it was at Laguna Honda to serve people. And we did have some cost analysis of how much cheaper it would be to provide the housing plus the existing Medi-Cal community services, that is non-nursing facility services, in someone's own home. And that was certainly part of our allegations in the Laguna Honda lawsuit.
Thank you.
Yes?
I have a side question, which is that I'm hearing an overlap between, I'm sorry, hard to flip, so apologize for Peggy and Richard, your two presentations. And the overlap that I kind of heard that didn't get discussed is keeping people who are in homes, who are at risk of losing their homes, from being on the street as an avenue towards getting access to health care and potentially housing services. So, yes, there are people who are homeless who use that as an avenue to get services, and it's pretty easy and dramatic to be able to track their outcomes. But how can we also use the statute to keep people from losing their homes when they're at risk of evictions or other threats to their housing?
Right, so with that population, so how can we not only help those who are experiencing homelessness, but prevent homelessness and poor outcomes for people who might be housed now but are at risk of homelessness? When it comes to supportive housing, let's see, generally, so there are ways that can be done. With there's a program called Rapid Rehousing, or I forgot what HPRP.
Homelessness Prevention
Rapid Rehousing, that's it. I know the acronym, I'm so DC, I know the acronym, but I don't know what it is. The Housing and Rapid Rehousing Program. That was part of the emergency spending from 2010, 2009, 2010. That addresses what you were talking about, where it wasn't necessarily a focus of ours at CSH, because we focused on the more vulnerable population, but our partners where we used to work at the National Alliance on Homelessness were heavily involved. And so it created a pool of funds that went out to communities to do exactly what you said, to do eviction prevention, to connect people with some light supports temporarily to help them keep their house, because we're thinking that these folks aren't folks that need ongoing services. They just need sort of a crisis intervention at the time to prevent their homelessness. Communities learned a lot. Some of the dollars weren't necessarily targeted to the right folks, but a lot of the dollars were, and communities have learned a lot about how to do rapid rehousing. And so now that those funds from the emergency pool are over, now the new homelessness program, the HEART Act, which is another acronym that I don't know, but the HEART Act is to implement what we learned from the rapid rehousing program. So HUD has issued guidance on how communities should be addressing those issues too.
Yes.
Are federal drug laws ever a barrier to you in providing harm reduction-based housing to people who might have addictions to illegal substances? Where, I mean, for example, if say someone was involved in low-level sales of drugs in order to support their own habit, how do you house that? I mean, are you able to work around some of the barriers that people would typically have to housing in that situation, or say they're going to continue, I mean, if they're going to continue to even use drugs, meaning landlords might want to evict that person,
Right.
and how do you work around that?
Right. So the question was, are existing federal or state laws regarding the usage of illegal substances, chemicals, or alcohol, but mostly chemicals, how does that impact our ability to actually provide a harm reduction supportive housing model, and how is it implicated, right? That's kind of the general question. And one example was, maybe I sold drugs for survival issues, and then got arrested and now have a record of narcotic sales on my my criminal record, and that may be a barrier for me getting housing. And the quick answer is on the ground. The answer is yes. Unfortunately, there is an impact. Many, of course, public housing authorities will not accept felons. Does that make sense? With criminal backgrounds, with drug felonies. Many landlords will not rent to people with criminal backgrounds that involve drugs. But part of the reason that our nonprofits are in place is to build relationships with landlords who are willing to take a risk. And so the quick answer is yes, there is always a negative impact by those criminal histories or the use of drugs. And like you said, I could use drugs in my apartment and then get evicted because I'm using illegal substances in my apartment. Two thoughts on that and how we mitigate that in our program on the ground. Number one, our case managers, one of their primary roles is to engage community rental housing providers in talking about our program and the benefits to our program. And so we recruit landlords. We simply recruit landlords to be on our side. And what we tell them is, if you're going to take our participants, you're going to take people that do not have stellar histories. Not only do they oftentimes have criminal histories, but they also have other barriers to successful community living. What we provide to you is consistent rent. We're going to get your rent paid every month. And when there is an emergency or a situation that needs to be addressed, we will be there to back that up because we're the case manager. That alone is a huge plus for many landlords because, of course, they rent to people all the time where there's no one backing them up. Does that make sense? So at least they know there's someone out there that's willing to clean up the mess. Is kind of the way we talk about it, cleaning up the mess. But the other thing we also talk about is that our permanent supportive housing employs something which I didn't review in the slides. We incorporate something called sticky services, which means that just because you goof up or you fail out of your first housing program placement doesn't mean that we terminate you from the program. So once you receive services from me as a permanent supportive housing provider, if we get you into an apartment and you use and then get evicted out of that apartment, we work with you when you have to go back to the streets or the shelter and trying to find you the next apartment, and we stick with you. We're sticky. Does that make sense? So we stay with you. So we assume that there's not a linear path to success. Does that make sense? People ebb and flow with recovery, right? It's not always successful the first or second or third time, and we need to stay with them if we're going to see long-term returns on that. So you have to create a service model that responds to that reality that, yes, there are these barriers, and you just have to find ways around those barriers.
And I would just add one thing the one thing that's harder than the substance use are sex offenders.
Yeah.
That's where it is an extraordinarily hard challenge. We have supportive housing that's targeted to reentry programs. And so with that population, given the nature of their crime and the parameters that are held, that are placed upon them as far as where they can be housed, that is the one that's harder than the substance use.
Actually, I just talked to a supportive housing provider yesterday who negotiated with the county to be able to house a sex offender, but it was quite the story to tell. What I was going to say is the homestead angle to your question about substances. You want to look at the homestead. right to community services, not the practical barriers there is talking about. The legal barriers is that people who are currently using people who are currently using illegal substances are not protected under the Americans with Disabilities Act as people with disabilities. But people who are recovering from a substance addiction and not currently using are protected by the ADA. And people who have alcoholism are protected by the ADA because alcohol is not a legal substance. So it's complicated.
Yeah. Great question. Other questions? Yes?
I work with a lot of organizations that are housing providers and also grant-funded service providers, really interested in Medicaid claiming, but as one said, even HUD money now is not for the faint of heart, and the challenges of all the HUD processes. And I'm really interested in the origins of Hearth Connection, that sort of centralized administrative core with the community service providers who are focused more on the services, and you guys providing more of the administrative core.
Yep.
How did that get started? How did you develop it?
Yep.
You know.
So the question was, there's a participant in the audience who works with other organizations that provide direct services that oftentimes have been reluctant to look at healthcare systems and funding for Medicaid because it's not in their expertise, and and is there value to an organization like Hearth Connection, my organization, and being an intermediary and providing that role for the community organizations, and kind of what was the history of our organization. Hearth Connection was founded in 1999, the same year as Olmsted, actually because a bunch of community leaders came together because they recognized that we had multiple system users, that was kind of the term, frequent users and multiple system users that were being seen in all these systems, and it was costly and really inefficient, and no one was really having great outcomes. And the question was, how can we make that system better? And the theory at the time was that there was a three-legged stool. There was social services, there was housing, and there was healthcare. And it would be great if all of those systems pooled their money together, and provided an intensive case management system that would stabilize people in housing in a way that would then divert people from those systems' use. So that was the theory in 1999. How it spun out in the early years is that we were a research project. We started out as a research project to even prove the point that these people could be stabilized, because it's hard to think about now, but in 1999, especially in the middle of America in Minnesota, this radical model called supportive housing was only being done in a couple of places, actually New York and San Francisco and LA. And actually, we had a small program in Minnesota actually running at the time that was supportive housing, but they didn't call themselves that. We didn't know what to call them. So we had to prove that we could take people with long histories of disabilities and homelessness and put them in housing and have it succeed and have reductions in cost. So we started out as a research engine in order to prove that with a cohort. And then, based on that research, we convinced the state to give us money, and we became the intermediary. This is self-interest, but of course there's value in an intermediary in the sense that we have the luxury of having staff time dedicated and expertise in looking at how to create systems change across multiple system areas, and looking at those policies where the mom and pop, I call mom and pop nonprofits, the people that are on the ground providing housing, they're responding every day to the crisis and the everyday running of a program. They don't have the luxury of spending hours and hours to think about, well, how do I talk to the liaison from the governor's office about getting this Medicaid proposal to the legislature? They're not there, and you need a level in between that's really able to pull that together, whether it's through an advocacy organization or an intermediary financial institution like myself. There is value, I think, that comes with that. Having said that, there are, of course, large nonprofit organizations that have been providing multiple business lines. They do disabilities, aging, family services, housing. They're oftentimes in a better position to look at doing Medicaid, medical assistance funding, because they're more sophisticated and they have a wider bandwidth of administrative support. So it also, I think, depends on the size of the organization you're talking about. But in our experience in Minnesota, the supportive housing homeless sector was these organizations that typically had less than $2 million in operation, annually. They're very small programs in different neighborhoods or different communities, and they just didn't have the capacity. So I think there's a positive role that we play. Thank you for letting me do that promotion. Yeah, other questions? Yes, in the back.
There was a reference to a private service that you would contract with, and if so, is that done in the bidding process, and how does that function?
So I think the question was, there was a reference to a bidding to a private entity. Was that to a health plan? Is that what you're talking about? The health plan?
Some health or something
Yeah.
related to.
So my project, the Medica Supportive Housing Project, it was a partnership between my organization and a health plan, which is another nonprofit corporation in the state of Minnesota. And we negotiated a contract with them. It was not a bidding. We approached them with a proposal and said, we know that you've just been given a bunch more people through medical assistance. We call it medical assistance, not Medicaid in Minnesota, but you just got a bunch of new Medicaid members, 5,000, 10,000 people. Some of them are going to cost you a lot of money because they're going to come to the hospital again and again, or go to detox, go to emergency rooms, go to inpatient treatment. If you could identify your frequent users that you also think are homeless, i.e. people that are on your list but you can't find them, give me that list, I'll house them with my rental assistance. And so our negotiation was, we presented we brought something to the table, to be honest. And what we brought to the table was, number one, money for housing. I actually have rental vouchers in my cachet to say I have enough housing vouchers to house 100 people tomorrow if you give me services, and I'll give you that money if you purchase the services from me. And I also brought with me my sophisticated database, what I call Copilot, which we developed over the last 10 years, which will help track outcomes for these participants. You're tracking your own outcomes. I want to track outcomes as well. Let's work together on a research modality. So it was pure negotiation. And it was, the hook was, I was going to save them money, and I was putting money on the table. Now, not everybody's able to do that, but I still don't think that prevents some people from negotiating, but it wasn't a bidding, it was a negotiation. Other questions? Thoughts? Any last thoughts from the panel? Well, thank you for coming, everybody. I do want to encourage you to fill out this evaluation form that is in the back. It's on a kind of a gold sheet of paper. It's very important for the commission to find feedback on our presentations, to find out if this is relevant to your work and how it's helping you in your local communities. I think everyone on the panel here is really thankful that you spent your Friday afternoon with us. I hope the chocolate helped. But I also really want to encourage you to go back to your communities and be the allies and advocates. We're on a national movement to end homelessness, and I really do believe that healthcare systems and the Olmstead ruling will play a big role in helping us further those goals in the next 10 years. So thank you, everybody.